who I thought I was introducing 5 people in one because it's multifaceted. This is Dr. Saadia Jan. She's an associate professor in Department of Family Medicine and team lead at St. Joseph's Hospital, as Zahid mentioned, in London, Ontario. She has special interest in mental health, palliative care, sexual assault, domestic violence, and women's health. And, Zahid also told us about Ozempic, how to lose weight. I think Saadia is going to tell us how to become more beautiful, because she also has interest in dermoscopy, and she wants her mission in life is to have 50% of family doctors get into dermoscopy.
So my name is, Dr. mentioned, Saadia Jan, and we hail from London, Ontario. Those are my disclosures, and they will not pose a conflict to what I'm going to be talking about today. I am going to mention a lot of brand names. However, I'm not going to benefit from any one of those. It's just, part of the trade, unfortunately, that we have to take those names. So the objectives were to look at 3 pearls that I could share with you. And obviously, we didn't do a needs assessment. So this is born out of my experience working with learners in our centers to see what was the most value-added thing that they actually learned from our practice when they come to do electives or they work with me in my dermatology clinic. So the 3 things are looking at doing skin scrapings. Number 2, incorporating or consider utilizing dermoscopy in your practice, which is a big passion of mine. And number 3, looking at some over-the-counter products, which are extremely important and useful in your management of certain dermatological conditions. So I'll try to fit that in 20 minutes. So incorporation of skin scraping for fungus in your practice, why is that important? It's important because one of the type of rashes that I've seen pose a problem even now. Sometimes I'm surprised by a rash that comes in or a patient that comes in with a rash, and you go through an initial trial, but then you find out after doing a skin scraping that darn, it was fungus. So we're going to go through that. Now, how many of all of our lovely colleagues here are working in primary care? Okay, great. And part of the challenge is to create content that hopefully should be beneficial for everybody. But, I'm sure even in any specialty, when you see a patient, there can be rashes. So starting off, infectious diseases are still very prevalent. Fungi, as we all know, are microorganisms, and they can cause superficial, cutaneous, subcutaneous, allergic, as well as systemic disease, depending on a patient's immunocompetence. They can occur as yeasts, which are usually unicellular buds, or fungi, which are more combination of filaments and buds as well. And most of these fungi are heterotrophic. And what that means is that they digest their food outside of their bodies and then they ingest them, right? And how they digest the food is by releasing certain enzymes that breaks down the keratin and proteins on the skin. So what do you think happens once those enzymes are released on the skin? If you don't have a good skin barrier, it can actually be an irritant, right? And that can lead to all sorts of rashes and dermatitis from that irritation. And that is why I feel that fungal infections, topical cutaneous fungal infections, can be quite a masquerader, actually. So the first way that they can manifest is ringworm, which we're all very familiar with, right? So usually the T. rubrum or the trichophyton species is responsible for that. They're usually annular, so ring-shaped, and they have an active border, which means the border on the outside is usually palpable. It's usually a bit elevated. And these can eventually grow, they can coalesce, they can become multimorphic, polycyclic. And their distribution obviously will be asymmetrical, right? Depending on what side the infection is on. It may or may not be itchy. Not all fungal infections are itchy. If there's a component of dermatitis, which means that the skin was irritated, it means that there can be some pruritus as well. There could be some lichenification if the rash was persistent for a very long time. From repeated scratching, the skin gets very thickened, which is what we call lichenification. So sometimes you'll see that as well. And it's more common in hot and humid areas. So you'll see it mostly in summers. So this is what, a very pathognomonic or hallmark a ringworm would look like, with that active border at the end right there. You can see how it's elevated. But how frequently would you actually see a classic annular rash like that? It's very infrequently, right? But you will. But most of these rashes are polymorphic, which means that they can manifest in multiple ways. So if you look at this one, this is also a tinea rash, but here you see more vesicles kind of at the end, right? So right off the bat, as soon as you see this, you may not be able to call this a ringworm or tinea, but it is because the edges are polymorphic, and this one manifests more as vesicular. Same thing here, very vesicular, small vesicles that are visible. This is a larger ring lesion or annular lesion. Here too, I think these kind of vesicles or erosions are throughout that rash. So very difficult to call this tinea right off the bat. And then obviously we have to pay attention to our dark skin patients as well, because rashes on them can look very different. So that's why it's really important to pay attention to skin scraping as well. Now, even though Melasizia is another yeast or fungus, sorry, it's not an yeast, it's a fungus, and it's lipophilic, but very commonly seen in tinea versicolor. And these are normal commensal, so it usually is present on the skin. It only proliferates and becomes pathogenic once there is humid environment or people who sweat a lot in athletes, or also sometimes people who consume a lot of carbohydrates, because a lot of those sugars are actually secreted in the skin in the form of keratin, and so that kind of provides the food for the fungi to grow on. Melasizia are important because, and the reason why they call versicolor is because they actually alter the melanocytes in the basal layers of the epidermis, causing either a discoloration, hypopigmentation, or hyperpigmentation in that rash. And they can obviously, because they secrete those enzymes, can cause irritation to the skin as well. Usually non-pruritic, and again, very common in oily and humid environments. So this is a rash that you'll see very frequently. So again, very white-skinned individual. You can see either, small papules like these, small macules, which are flat, papules a bit raised, or you can see a confluent rash like that as well. Now, when people have tinea versicolor and it's active, usually that rash is red because there's more inflammation. Inflammation always looks red on the skin, and it's usually palpable as well. So if you see somebody with this kind of rash, it's palpable, it's confluent on the back where they're sweating, maybe they're a runner or something like that, you have to think about tinea versicolor. But it means it's an active rash. On a dark skinned individual, you're more apt to see hypopigmentation because, again, here's where the melanocytes are probably eaten away by the enzymes that are secreted. So you may be able to see this too. Similarly, again, now this one, if you look at this one and that first picture that I showed you, right? So this one looks more red, whereas if you move on to this one looks more brown. And if you were to touch this, there's probably not going to be a lot of palpable rash present, but it'll be mostly a hyperpigmentation that'll be visible. Similarly, on a dark-skinned individual, you may just see this white kind of rash. Well, hypopigmentation or hyperpigmentation in tinea versicolor can be a long-drawn phenomenon, and even when the active infection is gone, the hypo and hyperpigmentation or pigmentary changes can actually last for quite a while. So these could potentially be rash tinea that is resolved, but there's some hypopigmentation. So we sometimes get patients coming in to say, "Well, I have this rash," and when you look at them, you know that it's probably just pigmentary changes. The actual infection is not no longer there. Similarly, melasizia is also present in seborrheic environments as well, because think about it, when you have oily skin, what happens? Lots of oil. Skin surfaces are going to pile up on each other, so lots of keratin sitting there. The fungus will go into that keratin, and because there's a lot of piling of the skin, if it hasn't been exfoliated, it has a lot of rich environment for food, and it'll just start growing underneath there. And as it starts growing, what is it going to do? It's going to start irritating the skin. And once that skin gets irritated and starts shedding off all of that keratin is when you start getting this seborrhea. So or I should say dandruff, or you start getting scaling on the face, scaling elsewhere in the seborrheic regions as well. And that's how you get seborrheic dermatitis. And because of those enzymes that are released, area underneath there is irritated. And so you actually start getting a dermatitis as well, right? So scalp, very commonly, we see it between the eyes. We see it in the nasolabial folds for most people. We see it around the eyes, in the eyebrows. These are areas that are highly seborrheic or oily. And so we tend to see them mostly in that area, behind the ears as well. Can be very pruritic, not because of the fungus, but because of the dermatitis portion of the seborrheic dermatitis, right? So even that was caused by a fungus, or actually caused by oiliness, that caused the fungus infection to proliferate. The irritation caused the dermatitis, and now you have a full-blown seborrheic dermatitis, right? So there's multiple events there. And so when you're treating it, you have to treat all of those steps. So that's what it looks like, right? So again, very commonly around the eyes, right there in the forehead, around the nasolabial folds on the cheeks. Those are very common areas for seborrheic dermatitis. You can see it again, any area that has sebum production, scalp, on the dark skin, you can definitely see some pigmentary changes as well as hyperpigmentation. Again, the mechanism is the same for that. And the fourth reason why I chose fungus is because there's also this entity called the id reaction. So people can come back, or patients can come and show you a rash that could be on their shoulder, could be on the backs, could be anywhere. But the original culprit is usually fungus between the digits, usually in between the toes. And how that works is that, think about it, if there's fungus, if there's irritation, what's going to happen? It's going to, the skin will react to that, right? And this is usually in individuals who have a propensity for eczema or for dermatitis, right? Because their barriers, the skin barrier is not intact. And so what's going to happen is, even though the infection or the trigger was in the feet, it can still trigger rashes elsewhere on the body, which looks like a dermatitis. So oftentimes when they're seen in primary practice, we'll say, oh, this person has eczema. Eczema is something, it's a genetic disease, but it's a completely separate entity. The rash itself is dermatitis, which is a reaction of the skin to any insult or any trigger. And in this case, it's usually between the toes. And so we call it a dermatophytide, ide, or id reaction caused by inflammatory fungal infection tinea at a distant site. So that's where it's really important to kind of first recognize it, have it on your differential, and then if you're considering it on your differential, to be able to then diagnose it by doing a fungal scraping. So id reactions will often look like this. So normally we see it on the chest, we see it on the hand like that, and also in the elbows, essentially anywhere. However, if you were to do a fungal scraping from this area, you will get nothing. There will be no fungus. The actual fungus is between the toenails. So management-wise, obviously, I'm not going to, in the interest of time, fungal infections can be, or they create a lot of rashes. We have to differentiate between an active and a resolved pigmented mycosis. It could be an id reaction, and fungal scrapings can definitely help you kind of differentiate that. And how do we do a fungal scraping? Normally in Ontario, I'm not sure about other provinces too, so feel free to let me know. Usually in our clinics, we just use a black paper like that. So a small black sheet that's folded on top of each other. It's about yay big. And then I take a small scalpel and kind of keeping it vertically over the rash, I just scrape off a little bit of epithelium, put it in the black paper, fold it, and then send it. And basically what the lab is going to do is they're going to take that, make a little slide with KOH on it, and then they will look at it under the microscope. So that's the first test that they're going to do. And so if they see buds, it's probably yeast, or if they see filaments like that, then they know that it's probably a fungus or a dermatophyte. And the first preliminary reports comes back telling us it's fungal elements were seen, and then they also will culture this and then send us a culture report as well afterwards. So that clinches your diagnosis. It takes about 2 to 3 days for this to return. Treatment of these rashes, I'm not going to delve into that, but obviously topical antifungals, any of the azoles, so ketoconazole, miconazole, used less, but it's more effective, and turconazole for more resistant cases actually it works really well. Obviously, if you have somebody who's very resistant, you can do oral antifungals. And then for people who have seborrheic dermatitis, you want to also treat the dermatitis portion, right? And so for that, you will need corticosteroids for that. Now, interestingly, and a lot of patients kind of laugh at this, bleach water soap. So people who get recurrent, people who are diabetic, people who are immunocompromised, or who eat a lot of carbohydrates, right? They will get repeated fungal infections. So if they soak their feet or they just do kind of soaks on their body with bleach water, it's actually an antiseptic for fungus. So bleach, regular, laundry bleach, 1 part bleach, 9 part water. I usually tell them just take a little bowl, make a concoction, and then just kind of soak your feet, soak your hands, or just your body, right? Do a body bath. So that's kind of the treatment for that. So first step, when you're seeing rashes that could potentially be fungus, do a fungal scraping instead. It'll help kind of delineate that. Dermatoscopes are handheld devices used for evaluations of skin lesion. And they have an illuminating light source that allows visualization of subsurface structure. So you can actually see the skin up to the dermoepidermal junction. Which obviously with the naked eye we're not able to take a look. So there's dermatoscopes come in multiple forms. The three main companies are Dermlight, Heine, and Illuco in Canada. This is the first one that I bought, and the first picture after I took a picture of my mole on my hand was actually a melanoma in situ. So right off the bat, the first picture I took of a patient paid off. So this is an actual picture of a melanoma in situ that I took with my first dermatoscope. You have the ability with these dermatoscopes to actually monitor lesions over time. So if you see here, what we can do is actually take pictures of moles. So this is from 2017, then I saw it again in 2018 and so on. So if you're unsure about a mole, but you don't think that it needs to be removed, you can actually monitor it over time, right? Instead of just quickly biopsying it or delving into it. How do you choose one? Obviously, level of competency, budget. Some of the high end ones are more than $2,500. Do you want to use this for mole mapping or just for diagnosis? Do you want the app to go with it, etc.? So those would all kind of influence what you buy. The way these dermatoscopes work is that they use light in different ways. So we can either polarize the light or we can use non-polarizing light. So basically, light, when it comes from a source, goes in all directions, right? So from the sun or from any bulb or whatever. But if you focus it, like right here, if it's focused, it's polarized. So this is what we get from it. So this is light coming from all directions. It's being reflected, refracted everywhere. But if you see here, if it's coming from one direction, you can actually see the base of the pond. So this is exactly how we can actually look at the skin as well. So these are pictures that show you that. And I'm gonna, in the interest of time, I'm gonna shorten this just to kind of talk about why dermoscopy is effective. Most of the studies that have come through, and again, it's a new science, have shown that it is extremely effective for diagnosing melanomas and pigmented lesions. But it doesn't stop there; it goes beyond that. And this one meta-analysis basically showed that a sub-analysis of that showed that actually it's also beneficial for primary care physicians to use, not just dermatologists. Actually, a lot of GP derms use this more than dermatologists use this. And the best way, this Cochrane study showed that if you use it for triage, it's a very powerful tool, and the way to learn it is through formal algorithms. There's one study that was done in Italy on, I think, 76 family doctors who were just given 1 day of training in dermoscopy, showed that the sensitivity and specificity for diagnosing melanomas skyrocketed and was really good. Even with that 1 day of training, and this is based out of histological data. Based on all of this, a bunch of American and Canadian GP derms got together and said, well, we need to then include this in our curriculum, right? If this is such a good thing, we need to use this. So this one paper came out recently, right hot off the press, and there is a QR code if you want to access it. It's available online. But basically, it showed what is within our scope as family doctors that we can use dermoscopy for, right? So it's not the full gamut of what is possible by using dermoscopy, but basically some of the things are here: angiomas, seborrheic keratosis, dermatofibromas, melanomas, hemorrhage, scabies, warts, and whatnot. And the way to learn it, because when you leave here, you'll say, okay, what's the next step? What do I actually do? So I want to leave you with two things. Number one, there's different algorithms that you can use to learn, right? One is diagnostic algorithm, which is more for the the experts in the area who will look at positive, the normal skin as well as abnormal skin. And then there are triage algorithms. So in the triage algorithms, you're just ruling in and out stuff, right? You're saying, okay, is this mole a melanoma, or is it just a mole, or is it a seborrheic keratosis? So if we start with those triage algorithms, that's a really, really good place to start for most primary care physicians. Just to give you an example, so if you look here, this is a scabies mite in the skin, and we call this the delta sign. So if we look at this under the dermatoscope, we can actually see the delta sign. And when you magnify it, this is the thorax, the eggs, and then you can actually see the burrow. So now for scabies, we diagnose it on the dermatoscope. We don't looking for burrows and what that. Not if you use your dermatoscope, it's a sure diagnosis. Similarly, basal cell carcinomas, very easily diagnosed using the dermatoscopes, and some of those features are right there. This is a great Dermoscopedia is a Wikipedia version of dermatoscope related topics, which I encourage you to see if you're interested in that. So dermoscopy is a great tool. There are multiple courses out there if you want to learn. I think it's a great thing for everybody to learn, and I'm really advocating for it to be included in family medicine training syllabus and curriculum all across the country. So we're working on that. The third pearl that I wanted to share with you today is looking at some of the over-the-counter products that are really useful in primary care practice. So I chose three, which will give you the biggest bang for your buck. So medicated shampoos, mostly for seborrheic dermatitis and itchy scalp, keratolytic creams and lotions, and retinol and skin regenerative products. So within the shampoos, the first one is Nizoral. It's a fantastic product that is available, and if you look at it, it's just ketoconazole. So if you've treated a patient with fungus with azole antifungals like ketoconazole, miconazole, turconazole, even Lamisil, and the rash is gone, but you know that this is a person who's not very difficulty with hygiene, etc. They can't bathe well, etc. Well, give them the shampoo to use as a body wash, right? So they use it on their scalp, they put it on their body as a body wash. I tell them just wait for 5 minutes after applying it, and then you can rinse it off. So basically, you're using this to treat the whole body, making sure that they don't have a proliferation of antifungal of dermatophyte on their skin. So great product to use. Another version of that is Sebcur. So if somebody has seborrheic dermatitis in the scalp, you can give them Nizoral. But what about those plaques? What about the seborrhea that's there? You've got to lift that, right? Remember how seborrheic dermatitis is caused by the oil, which causes the skin proliferation. Then the fungus gets in, right? So what's going to lift the oil? What's going to lift all of that dead skin that's there? Well, shampoos like these, right? So what does this have? If you look at the ingredients right there, it has salicylic acid 4%, coal tar 2 to 4%, and some really soothing menthol-like products. So this shampoo will actually help. The salicylic acid cuts the grease. What cuts the grease? Acid, right? So salicylic acid, coal tar is very good for things like psoriasis, anything where you have hypertrophy of skin and so on. So you will just lift that and really clean the scalp. So this is a great shampoo to use wherever there's dandruff. And then this third shampoo is a combination of the first two. It's got the antifungal as well as the keratolytic aspect, right? So don't go by what they're saying that it's the number one. It's not me saying I just copied and pasted what they're saying. But basically, it has selenium, which is an antifungal. It has the salicylic acid. It has the ceramides, the vitamin E, menthol, etc., to really soothe the scalp. So right now, this is one of my favorite shampoos to give to people because it's a one-stop shop for anything to do with scalp itchiness, right? Whether it's psoriasis, whether it's seborrheic dermatitis. So those are the three shampoos. And number two, keratolytic agents. So keratolytic agents, you're familiar with exfoliation, right? What do we do when we have thickened skin? We have keratosis pilaris, or you just want to exfoliate your skin. You use a mitt or you use a brush to exfoliate. That's physical exfoliation. These creams are chemical exfoliants, right? So Uromol 20, Urosec, and they go to different percentages. So 22 means there's 22% urea and there's 20% of urea. This is probably the most economical. Costco, from Costco, this dermal therapy skin for, I call it the foot cream. Everybody knows it by the foot cream. So I say to the patient, just go to Costco, get the foot cream from there and start using it wherever there's hyperpigmentation, there's thickened skin, there's any kind of hyperkeratosis. So this is 25% urea, the one from Costco. Uromol or Urosec can go up to 40%. That's the highest. And usually these creams should be used 3 times a week because they can be irritating as well. So basically you use it, but all the rest of the days you can use your regular moisturizers or so. So again, some of the conditions you can use it for is cirrhosis, psoriasis, calluses, KP or keratosis pilaris. Any lichenified cream or itchy skin as well would benefit. So this is 3 times a week, right? Or alternate days. But if you want somebody to use it more regularly, the lotion versions of these are fantastic because they have the 5 to 10% urea, but they also have moisturizers in them as well. So instead of using regular Gold Bond or whatever is available, you can advise them to use Uromol 10 lotion or Eucerin lotion. They have 5 to 10% urea. So they're both exfoliants and keratolytics as well as providing moisture to the skin. And moving on now to the third thing, which is sun damage repair and retinols and vitamin. There is so much in the cosmetic industry. It's one of the fastest growing industries. Everybody wants to take care of their skin, look good, reverse sign of aging. And retinols or vitamin A derivatives have been consistently one of the best ways to regenerate sun damaged skin. They don't just exfoliate skin, which I know there's a bit of a misconception about that. But what they actually do is they get into the cells that have been damaged by the cells. And how do cells get damaged by the sun? The sun rays, the UVA and V, actually change the RNA and DNA of the cells in the skin. And that's where mutations occur. That's how you get actinic keratosis. That's how you get non-melanoma skin cancers. So when you have a cell that has abnormal DNA and RNA, vitamin A derivatives, so your retinase, your retinols actually go into that cell and they repair those cells. So that's why they're so good. Cosmetic grade retinoids are called retinol. It's a different molecule. It's a smaller molecule. That's why it's been approved by Health Canada to be used in cosmetics. They've come a long way. If you want to do a prescription, it's usually the brand name Retin A, Steva A, etc. So these have come a long way. Some of these newer over-the-counter products actually have retinol in it. B3 niacinamide is there was a recent study that was done about 7 or 10 years ago. If you ingest 500 milligrams of B3 twice a day, it actually decreases the number of non-melanoma skin cancers that a person can generate, or the incidence goes down. And you know, B3 used on the skin can actually cause brightening, similar to B3, similar to vitamin C and other whitening agents as well. Let's just say the cosmetic industry has started using all of these products in various configurations to help improve the texture and the appearance of the skin. Brand, very common, available everywhere, actually has retinol in it. It has fantastic, vectors that actually house all of these, very luxurious on the skin. Similarly, Olay, again, a very affordable brand, has retinol in it. It has peptides in it as well. And it actually has sunscreen as well. So that's the SPF of 25. So if somebody can't afford a lot of medications, just one over-the-counter, relatively inexpensive brand will help them regenerate their skin and sun damage. You'll see a lot of these products. I take my residents on a field trip at least twice a year. We just go to our closest Shoppers Drug Mart and we go through all the aisles and look at what's available. Because your patients are going out there and they're looking at all of those products and they're saying, gee, what can I use to make myself beautiful? Well, here are some of the products, right? So if you understand what's in them, you can actually advise them from a price perspective. So again, do a field trip, go to your local Shoppers and look at everything that's out there. You're looking for retinol, you're looking for vitamin B3, you're looking for vitamin C, and you're looking for sun protection. If you find that all in one cream, hooray, that's great. Thank you.